Hello and welcome. My name is Corin Thald, and I am Mercodia's Medical Science Liaison, and I'll be the host of today's exciting webinar. Before we begin, I would like to mention that all of your questions will be held until after the presentation, and at that time, I will read any submitted questions and give our speaker a chance to answer them. Our distinguished speaker is Dr. Stephen Russell. He is Assistant Professor of Medicine at Harvard Medical School and an attending physician at Massachusetts General Hospital. He is board certified in internal medicine and endocrinology, diabetes, and metabolism. Dr. Russell is a principal investigator of a collaboration between Massachusetts General Hospital and Boston University to develop a wearable bionic pancreas system for automated glycemic management in people with diabetes. His other projects include evaluation of continuous glucose monitoring technology, methods for automated management of glucose in hospitalized patients, investigations of methods to improve insulin pharmacokinetics, investigations of stable formulations of glucagon, and development of a device for minimally invasive continuous insulin monitoring. Dr. Russell's research is supported by the National Institutes of Health, the Leona M. and Harry B. Helmsley Charitable Trust, the Banting Foundation, the American Diabetes Association, and the Juvenile Diabetes Research Foundation. I'm very happy that he is with us today to talk about his work on the bionic pancreas. So without further ado, Dr. Stephen Russell.
Thank you very much, Corinth. It's a pleasure to be here, and I'd like to thank all the attendees for listening. I'm going to be talking to you today about our work to develop a better way to manage diabetes. And to put this in perspective into historical context, I'd like to mention what the situation was before 1922, before the purification and availability of insulin. You can see on the slide that before the development of insulin, people who developed type 1 diabetes really had a very short time to live. The only effective treatment was starvation, limitation of almost all carbohydrates. And so you can see on the left here is a young woman who had the good fortune to be diagnosed shortly before the purification of insulin. Here, another young boy. And this is just 3 months later after she started receiving insulin injections. So what was previously a death sentence, diagnosis of type 1 diabetes, was now a manageable illness. And so at the time, I think physicians felt that we had conquered diabetes, but it quickly turned out to not be quite so simple. The real issue that continues to this day is that when you take insulin to manage diabetes, you're walking a tightrope between blood sugars that are too low, which cause immediate complications, and too high, which cause long-term complications. And the range of blood glucoses that are safe is really not very wide. If blood glucoses are too high over a long period of time, and that means an average over 150 milligrams per deciliter, that results in an increased risk of heart disease, roughly a 2 to 5-fold increased risk. And diabetes is the leading cause of preventable blindness, of kidney failure, and of non-traumatic amputations. And we know that if we could get to that average of 154 milligrams per deciliter, all of this would be drastically reduced, if not eliminated. But it's really difficult to do. In fact, the current average glucose for people with type 1 diabetes in the United States is about 200 milligrams per deciliter, quite a bit above that target. And the primary limiting factor in achieving those goals is the risk of hypoglycemia that occurs when we try and achieve them. Once blood glucose goes below 60 milligrams per deciliter, you start to develop symptoms like tremor and sweating. Then below 50 milligrams per deciliter, confusion, which can lead to accidents. And below 40 milligrams per deciliter for any extended period of time, it can result in seizures and, if not treated, death. So it's this constant tightrope that patients walk. And this is some data to support those generalizations I was just making. This is data from the Diabetes Control and Complication Trial, where patients were randomized to one of two treatments: conventional care, which gave them a hemoglobin A1C of about 9%. Hemoglobin A1C is a marker of long-term glycemia. The hemoglobin A1C can be converted to the average glucose over the last 3 months or so. And this hemoglobin A1C of 9% is average blood glucose of over 200 milligrams per deciliter, somewhere in the range of 210, 215 milligrams per deciliter. Another group was randomized to a very intensive multiple daily injection or insulin pump regimen. And with a lot of support, they were able to lower their average blood glucose down to about 150 milligrams per deciliter, or an A1C of 7%. And this was maintained over the course of 9.5 years. And the results were very dramatic. There was a 76% reduction in the new onset of diabetic eye disease and a 54% reduction in the progression of diabetic eye disease in the intensive group rather as opposed to the conventional group. And they also found a reduction of kidney disease of 50% and nerve disease, small vessel disease, of 60%. So the results were really very dramatic. The study was then carried on over a much longer period of time, another 18 years, in fact. And after the intensive support was removed from people in the intensive arm, and the people in the conventional arm were trained to do the intensive regimen, but again, without the very frequent support of medical physicians and doctors and dietitians and so forth, you saw a coming together of the average glucoses of these two groups. But interestingly enough, the group that had intensive care for those 9.5 years had a reduction of cardiac disease of 42% over the following 18 years, and a 60% reduction in non-fatal MIs, stroke, or cardiovascular death. So again, the benefits of tight glycemic control are dramatic. And we know that if we got everyone who has if we brought the average glucose that's average of 8 to 8.5% A1C now, if we brought that down to the goal of the American Diabetes Association with a A1C of 7%, we would reduce the risk of diabetes complications by 70 to 80%. The problem is, as you reduce the hemoglobin A1C with current technologies, the risk of severe hypoglycemia, that is hypoglycemia that requires the assistance of another person, increases as well. And so we would predict a 50% increase in risk of these severe hypoglycemic events that can result in death by making that same change, by bringing everybody in the United States down to an A1C of 7% with current technology. So what is the current technology? This is usual care as it stands now. Patients with type 1 diabetes have to measure their glucose many times a day and determine the amount of carbohydrates they're going to take in a meal, which they do by either reading labels or weighing their food or estimating based on a book that many of them will carry around or their experience. They can also take advantage of new technology, continuous glucose monitors that use a small sensor that just goes under the surface of the skin and measures the glucose in the interstitial fluid in the subcutaneous space, and then converts that to a blood glucose value. And so that gives much more frequent blood glucose information to patients, and it can be very useful, but only about 10% of patients with diabetes use this technology. Once they gather all this information, they then have to make sense of it and convert that information into actionable intelligence. They have to figure out the difference between their current glucose and the target glucose, and then multiply that by a factor to determine the amount of insulin to correct any deviation in the glucose. And then they add to that another amount of insulin that's for the carbohydrates that they're going to eat, and they have to calculate the number of carbohydrates in grams and multiply that by a factor to determine the amount of insulin for the carbs, and then add those two together and then make any adjustments based on their activity or their insulin on board and determine a dose. Not a simple thing to do. Then they have to deliver that dose, and that can be either done with a syringe or with an insulin pump. And then you have this black box of patient physiology. And any patient with diabetes will tell you that they can do the same thing, same meal, same starting glucose, same dose of insulin, and they'll get a different result every time, which is a source of great frustration. And people have to do this many, many times a day. We recommend roughly 10 times a day to get very good blood glucose control. People generally do it anywhere between 4 and 15 times a day. And despite this amount of work, most people in the United States with type 1 diabetes aren't able to achieve an A1C of 7%. And it's the risk associated with diabetes, this constant fear of hypoglycemia, the long-term concern about complications, the fact that patients with diabetes are really on their own, having to do it themselves, and it's really unique in that regard among diseases, that I think diabetes has a unique impact on people's lives. This is a collection of tattoos from people with diabetes that part of a much larger collection that I've amassed over the years. There are very few diseases where people tattoo their diagnosis on their skin, but they have very good reason to. If they're found down, for instance, unconscious, they want the EMTs to know that what they probably need is IV glucose. Or if they're acting strangely or disoriented, that they want a police officer or an EMT to know that they're not intoxicated but probably hypoglycemic. So it has a practical method. There's a practical reason for it, but I think it's also because people get these tattoos for the same reason that my grandfather did when he returned from the Pacific Theater of World War II. It's an esprit de corps in a sense of surviving something very, very difficult. And there's a pride about making it from day to day that's expressed by these tattoos. So we would like to change this paradigm. We would like to use all the information available from these continuous glucose monitoring devices and send that information to a computer algorithm that will make all of the dosing decisions, and it will automatically command insulin pump to deliver the doses. We'll still have this black box of patient physiology, but if the algorithm is smart, it will learn what the patient needs. And because it's making these decisions very frequently, we get blood glucose information every 5 minutes from one of these continuous glucose monitors. We can make decisions 288 times a day. So we have to make much less investment in any particular decision. And if things don't go as expected after a particular dose of insulin, we can always give more at the next step or at a later step. Or we can give much less insulin. We can turn off insulin for a while and allow some of the insulin to wear off. And the algorithm can do this 24 hours a day, whether or not the patient is paying attention, whether or not they're asleep. And we think that this is going to be the future of diabetes care. And that will reduce the anxiety and improve the care of people with diabetes. So our bionic pancreas, a term that we prefer to artificial pancreas, is unique in a couple respects, but one of them is that we are replacing two of the hormones that are missing in type 1 diabetes, not just one. It's well known that people with type 1 diabetes are missing their beta cells that produce insulin because they've been destroyed by an autoimmune attack. But what's less well appreciated is that in the absence of beta cells and the insulin that comes from them, the alpha cells that produce glucagon very rapidly become dysfunctional. Their job is to produce glucagon whenever the blood glucose is low or is threatening to become low. And that glucagon then acts on the liver to cause it to break down glycogen and release glucose into the bloodstream so that the liver becomes a net glucose-producing organ under those circumstances. And that buffers the effect of insulin and can prevent and treat hypoglycemia. Without glucagon, patients with diabetes must take oral carbohydrates. They must eat sugar every time they threaten to go low or are actually low. And this takes a little while to work, and it also is something you can't do if you don't have sugar available or if you're unaware that you're low because you're asleep. And glucagon delivered automatically by a bionic pancreas allows us to automatically prevent and treat hypoglycemia. Now, of course, we want to be as smart as we can be with insulin delivery so that we need the minimum amount of glucagon, but there are times when even if you've delivered insulin perfectly, glucagon is still important. And the point that I want to make with this slide is that even quote-unquote perfect insulin dosing wouldn't solve the problem of glucose control in diabetes, and that's because there are other things that regulate blood glucose besides insulin, and one of those is exercise. We know from our studies using the bionic pancreas with exercise in a controlled circumstance, that even very modest exercise like walking or pedaling a bicycle, a stationary bicycle at a fairly modest pace, will cause the blood glucose to drop very, very rapidly. An average is about 2 milligrams per deciliter per minute, but it can be much faster than that. And that means that if you come into a bout of an exercise with a well-controlled blood glucose, within 15 minutes, you will be hypoglycemic. And stopping insulin delivery right at this point is not going to solve that problem, because insulin, when delivered into the subcutaneous tissue, as we do with an insulin pump, is absorbed quite slowly. It takes about an hour on average for levels to reach their peak after a dose given subcutaneously. And then it takes a long time for those levels to clear. So stopping insulin delivery here is going to have no appreciable effect on insulin levels here. And there's no way by just stopping insulin delivery you could prevent this hypoglycemic event. The only way is by automatically delivering glucagon to change this trajectory, or by taking oral carbohydrates. So the bionic pancreas control algorithm that is used in our system was developed by my colleagues Ed Damiano and Firas Khatib at Boston University. And it is also very unique in that it uses only the patient's weight for initialization. Bionic pancreas doesn't know anything about past insulin dosing. It's also unique in that it then operates solely on the basis of glucose. It doesn't know anything else. We don't tell it anything about exercise. It doesn't know anything about the patient except the glucose values that are coming in every 5 minutes. And it uses its insulin dosing and the response to that insulin dosing to adapt to the individual's insulin needs. And it takes about 18 hours to hone in on the insulin needs of that individual. And of course, it does so with a moving window. So if those insulin needs change, it can adapt to that again over the course of 18 hours or so. And we think this is really important because people's insulin needs change based on their activity level. They change in women based on their time in the menstrual cycle. They change during development. Small children have much lower insulin needs by weight than adolescents, and then adults have lower needs or similar on a per weight basis to younger children. Also, you need less insulin, for instance, if you become sick and you're not eating. But on the other hand, if you have a lot of inflammation, your insulin needs may go up dramatically. The system predicts pending insulin action with a model for absorption and clearance to avoid insulin stacking. And we do allow the patient, but we don't require them, to provide a meal announcement. And this is only a qualitative meal announcement, and I'll explain that a little bit more later. But that allows them to give some of the insulin for a meal up front if they know they're going to eat, but this is not necessary to achieve good glucose control. So we started this doing human studies, or preparing to do human studies, in 2006. We started our first human studies in 2008, and we published our first human studies in 2010. And this was a system where we were actually measuring glucose directly, typing those results into a laptop, and then getting the results, what insulin and glucagon, the control algorithm says were needed, and then programming those into insulin and glucagon pumps every 5 minutes. So this was very labor intensive, but it allowed us to quickly move through these studies and work on the control algorithm, learn some lessons, and then move on in the future to more automated systems. But this first study already showed how the system would work. And so I'm showing you one of the results from the very first study to show the behavior of the bionic pancreas. This black set of circles is the patient's blood glucose. The 70 to 120 range is in green, and the 120 to 180 milligram per deciliter is in blue. And you can see that the patient had a well-controlled blood glucose when they came into the study. They ate a meal that contained a lot of carbohydrates, 108 grams of carbohydrates for dinner. The blood glucose started to rise, and the bionic pancreas responded by starting to dose insulin, which is denoted by these blue strikes downward. And for instance, this strike downward is about 1.75 units. So it took multiple doses to give the entire insulin dose for that meal. It paused and then gave a little bit more. And then the blood glucose started to come down. And you can see that if it continued at this trajectory, it looks like it would go into the hypoglycemic range, so the Bionic Pancreas gave a small dose of glucagon. And this is quite a small dose. This is 1.5 units on an insulin pump, or 15 micrograms of glucagon. So this is 1.5% of a rescue dose of glucagon that you would get in one of those red kits from Lilly. Even though it's a small dose, though, you can see it causes an abrupt change in the glucose trajectory. It slows down the fall, and then additional smaller amounts of glucagon are given to rebound the blood glucose up to about 125 or 130 milligrams per deciliter. And a gentle interplay of insulin and glucagon overnight keeps the glucose in the normal range. And you can see that there's a similar pattern for the breakfast meal and the lunch meal the next day. And the glucose control was great. Over a 24-hour period, the average glucose was 128 milligrams per deciliter, which, if continued over the course of 3 months, would give an A1C of 6.1%. And this was done with no significant hypoglycemia. The lowest blood glucose was 66 milligrams per deciliter. And the total amount of insulin used was very similar to what this particular patient used when they were not on the Bionic Pancreas. And the total amount of glucagon was modest as well, 1/3 of a milligram. And a milligram is the FDA-approved rescue dose for severe hypoglycemia. 1/3 of a milligram was used over this full 24-hour period. We then moved on to a fully automated system that used a continuous glucose monitor as the input, automatically sent the data to a laptop, which then automatically controlled these pump controllers. These are actually Insulet PDMs, which wirelessly control Insulet Omnipod patch pumps. And we used this system for several more studies that I won't have time to go into today. But we, in these studies, lengthened our period of control to 2 days. We added exercise. And, of course, we were using a continuous glucose monitor signal. We also did a lot of work to validate the accuracy of various continuous glucose monitors. And in our most recent study, which was just published in the Journal of Diabetes Science and Technology this year, we compared the Abbott Navigator, unfortunately no longer available in the U.S., the Dexcom G4 Platinum, which is their most recent CGM, and the MiniMed Enlite, or Veo, which is what's associated with their current 530G pump. And what we found is that there was big differences in the performance of these systems, and that the Dexcom G4 Platinum had the lowest average error, an average deviation from the reference blood glucose of about 11%, compared to an average error of about 18% for the MiniMed device. So we decided to use the Dexcom G4 Platinum for our future studies. And this is the system that my colleagues at Damiano and Firas Khatib, along with some collaborators in industry, built. It uses an iPhone to run the control algorithm instead of a laptop. If you were to turn this over, you would see the receiver for a Dexcom G4 CGM, and it wirelessly controls 2 tandem t:slim pumps, one for insulin and one for glucagon. And so this system, which can fit in, if not one pocket, at least 2 pockets, replaced this big laptop-driven system that we had to move around on an IV pole. So one of these insulin sensors is placed on the skin, and the transmitter sends the information to the G4 Platinum receiver. That's back-to-back in this device with an iPhone, and they're connected with a wireless interface. And then the iPhone wirelessly controls via Bluetooth these 2 insulin pumps, which give insulin or glucagon through subcutaneous infusion sets, providing us a wearable Bionic Pancreas so that we could do outpatient studies. The user interface looks like this. If you have the iPhone in the landscape mode, it shows the blood glucose over time. These stars are reference blood glucoses, and normally you wouldn't put that many in there, but this person has checked their reference blood glucose frequently, and it shows that the CGM, which is the black circles, is tracking very closely to the reference blood glucose. It shows the insulin doses that are given, the glucagon doses that are given, and the total insulin and glucagon doses average over the day. It shows the current blood glucose and the maximum, average, and minimum blood glucoses over time. If you turn it into the portrait mode, it shows the same information about the current and mean blood glucose, but it also has a row of icons at the bottom where one can control or can interact with the device. So at the bottom, you see there's this knife and fork icon. And if you hit that knife and fork icon, that's how you announce a meal if you choose to do so. You'll tell the system it's a breakfast, lunch, or dinner. And you will tell it how many carbs you're having compared to your usual meal. It can be a typical amount, less than typical amount, more than typical amount, or a small snack. One doesn't have to count carbohydrates. So really all you need to say is whether it's typical for you for that time of the day. And this is going to be much easier for patients. And then the system learns what you mean by that and then attempts to give 75% of the insulin that you would typically have for a meal of that size. And then if you're satisfied with it, you can proceed with the bolus. And, of course, we suggest that people only do that when they have the food in front of them. So we used this system for 2 outpatient studies. One, which was called the Beacon Hill study, was done in adults who had type 1 diabetes and who had no endogenous insulin production. In other words, their pancreases were incapable of making any insulin on their own. They had a negative C-peptide after a meal challenge. And they agreed to stay within this area of Boston, essentially the entire downtown Boston area. For those of you familiar with Boston, this is Massachusetts Avenue here. So we have the Back Bay and Beacon Hill where Massachusetts General is in the north end. Massachusetts General is about right here. And so they stayed in a hotel near Massachusetts General Hospital at night. And then during the day, they had the run of this area of Boston. And they could do anything they liked during that period. We got them a gym membership, and there was a gym at the hotel. They could walk around. They could... if they happened to work in this area, they could go to work as usual. Many of them didn't, so they essentially did tourist things in Boston or worked from their hotel room or went to basketball games or saw the sights. And we made no restrictions on what they would eat or when they would eat it. And so quite a number of them spent some time in the North Food, availing themselves of the excellent Italian cuisine that we have in Boston. And we gave them a food subsidy of $250 over 5 days to encourage them to do that. At night, they stayed in a hotel, and they were monitored remotely from a nearby room by nurses. And then during the daytime, we simply had a nurse follow them around everywhere they went for safety purposes. Tried to maintain an inconspicuous mode, but we were there to take care of them. And this is what allowed us to take the system out into the outpatient system or outpatient setting for the first time. And so 20 patients each participated for 5 days in this study, and then we compared their blood glucose control with 5 days at home taking care of their own diabetes management, and we monitored them with a blinded continuous glucose monitor, and we gave them another $250 and encouraged them to go out to eat. So they participated in these 2 arms in random order. So what I'm showing you here is a continuous glucose monitoring trace over a 5-day period of time under usual care. And this is somebody with excellent average glucose. They had 132 milligrams per deciliter over this 5-day period, which would be a predicted A1C of about 6%. And you can see that although the average was good, there was quite a few highs. Blood glucose is above 180 milligrams per deciliter, and also quite a few lows. This white area is 50 to 70 milligrams per deciliter. So this person spent a significant amount of time, less than 50 milligrams per deciliter, less than 70 milligrams per deciliter, and even sometime less than 50 milligrams per deciliter. And you can see here's a period where the CGM flatlined at 40 milligrams per deciliter for an extended period of time, almost an hour. So that they may have been close to a seizure threshold at that point. Or the sensor was perhaps under pressure, and that can occasionally lead it to cause artificially low sensor readings. And so you can see that even though they had a good average, they spent 7.1% of their time less than 60 milligrams per deciliter and 11% of their time less than 70 milligrams per deciliter. So they would have an excellent A1C, but at the cost of these low blood sugars, and they had to take oral carbohydrates multiple times. Each of these little tick marks is a time where they had to take oral carbohydrates to treat hypoglycemia. This is the same patient for 5 days on the Bionic Pancreas. And you can see that they have much less variability in their blood glucose, much less time above 180 mg per deciliter, much less time below 70 milligrams per deciliter. In fact, at the beginning here was the only period of time when they spent time less than 70 milligrams per deciliter. And this is with the same CGM system. And you can see that even though the average glucose here was very, very good, the average glucose under Bionic Pancreas control was even better in this subject, 117 milligrams per deciliter. But this was done with a very, very small amount of hypoglycemia, 0.5% of the time less than 60 milligrams per deciliter, and 0.8% of the time less than 70 milligrams per deciliter. So a significant improvement in mean blood glucose, and at the same time, a very dramatic reduction in hypoglycemia, two things that don't typically go together. And you can see also that this person, during the Bionic Pancreas arm, never had to take oral carbohydrates to treat hypoglycemia. This is a summary of all the results of the patients in that study. And on the left, you can see each of these points is the average glucose under usual care for each of the subjects in the study. And on the right is the average glucose on the Bionic Pancreas. And they're connected with a line. So you can see the trend of mean blood glucose for each of these individual subjects. The size of the circles corresponds to the time they spent less than 70 milligrams per deciliter. So overall, the people on the Bionic Pancreas arm had a lower mean glucose of 133 milligrams per deciliter as opposed to 159 milligrams per deciliter. And they had less hypoglycemia, on average half the amount of time less than 70 milligrams per deciliter. And you can see that for individual subjects, sometimes the amount of hypoglycemia reduction was much more significant than that. In some cases, going from significant hypoglycemia to essentially no hypoglycemia. And it was interesting that it didn't seem to matter what the mean blood glucose was. People came in with a very narrow range of average blood glucoses under Bionic Pancreas control. And this is a feature of the system, its adaptive nature. If the mean blood glucose is too low, as it was in this patient, the system will actually give less insulin and increase the mean blood glucose. And if it's too high, it will be more aggressive with dosing, but also more smart in when the dosing occurs to bring down the mean blood glucose. And you can see this individual had a mean blood glucose of, I think it's 240 or so, and yet on the Bionic Pancreas had a mean blood glucose of 120. So we believe that this system would be able to give anyone, regardless of their mean blood glucose under usual care, an average glucose in this range. And importantly, all of the subjects had a mean blood glucose on the Bionic Pancreas that was less than 154 mg per deciliter, which corresponds to an A1C of about 7%. So that means that everyone in our study would have met the American Diabetes Association guidelines for mean blood glucose and would have dramatically reduced their risk, at least this cohort, would have dramatically reduced their risk for long-term complications. We did a similar study in a diabetes camp setting in adolescents who were 12 to 20 years of age. The older subjects were counselors in training or counselors at the diabetes camp, and the younger subjects were campers. And we did a randomized crossover design where they spent 5 days at a camp, at a diabetes camp, the Joslin or Claire Barton camps, under usual camp care, which is very intensive, really, compared to just normal outpatient care. They have counselors in their cabin, almost all of whom have diabetes themselves, and a nurse with each cabin, and they make sure they never miss an insulin dose. And a doctor or another provider reviews their insulin dosing every day and makes adjustments. So this is a very intensive care, and actually they did a lot better in the camp based on their average blood glucose than they did at home. And then we compared that to 5 days on the Bionic Pancreas, and we had 16 boys and 16 girls for a total of 160 Bionic Pancreas days. So this was actually a larger study than the Beacon Hill study, where we had 100 Bionic Pancreas days in total. You can see they were a little rough on the equipment. This was only a day into the study, and they'd already scraped the Boston University label off of the Bionic Pancreas. And some of the smaller kids had to carry a lot of hardware. Here's the 2 insulin pumps and 2 infusion sites. And of course, moving forward, we're planning to consolidate all this hardware into a much smaller footprint. But in this study, they had to be separate. And this was a CGM transmitter on this 12-year-old subject that's held on with some extra tape because they had a tendency to sweat off all of the equipment. Again, this is one of the subjects under usual care at the camp, and you can see that camp care is very challenging despite all the supervision they have. They tend to go very high and very low because they're eating big meals and then they're exercising very, very hard. And so you can see that the average here in this particular subject was high, 197 milligrams per deciliter, but yet they still had almost 5% of the time in the hypoglycemic range and a tremendous amount of glycemic variability. That same kid on the Bionic Pancreas had much less glycemic variability and a much lower average of 149 milligrams per deciliter, and at the same time, a much lower amount of hypoglycemia, 0.8%, less than 60 milligrams per deciliter. You can see some evidence of the adaptation of the system. The system starts off very conservatively, and this particular child used a lot of insulin, and so the size of the glycemic excursion after the first meal was pretty significant, but the size of the glycemic excursion after the next meal was less, and then the Bionic Pancreas brought them under much better control. So you can see this is for the first 24 hours had a lot higher average than the subsequent 5 days, which is very typical of what we see with the Bionic Pancreas. This is the same diagram I showed you earlier. So we had a huge range of mean blood glucoses in the kids on the usual care, the camp care, and a much tighter range of glucoses with the Bionic Pancreas. This is an exception. This is the only camper who had a higher average glucose than we like on the Bionic Pancreas, and this was due to a malfunction of the Bionic Pancreas. We then fixed it, and on days 3 through 5, if you were to just look at the average on days 3 through 5, that subject would fall right here. So we have been able to show here that in adolescents, very challenging subjects were able to achieve the same kind of average blood glucose control and the same sort of tight distribution that we saw in the adults. So an average of 158 milligrams per deciliter under camp care, which is really excellent and better than they were getting at home. In fact, their average glucose based on their A1Cs at home was all the way up here, and 142 milligrams per deciliter on the Bionic Pancreas. Another interesting note is that the amount of insulin used was actually less on the Bionic Pancreas, not statistically significantly so, but was actually less despite a much lower average. And this is because the Bionic Pancreas is redistributing the insulin dosing. It doesn't have to use more, it's just smarter about when it uses it. And so these subjects in the control group and the Bionic Pancreas group are eating the same amount of food, they're undergoing the same amount of exercise. And so this is very convincing evidence that the Bionic Pancreas doesn't use more insulin to achieve these better glucose results. We then completed another study this year in younger kids, 6 through 11. This is our youngest and smallest subject who's ever been treated on the Bionic Pancreas. She's 6 years old, and you can see she's holding the Bionic Pancreas, and the pumps are beside her here. And we completed a study with 18 children in the 6 to 11 age group this summer. And here's that same diagram again, and you can see the results are very, very similar. A range of blood glucoses, significant amounts of hypoglycemia, much lower mean glucose, and a tighter distribution of glucoses, and less hypoglycemia. Here we've added the triangles, which show the amount of time greater than 180. So this size of the triangle is proportional to the time greater than 180, and you can see we spend a lot less time above 180 on the Bionic Pancreas. We are now involved in our first true home use study of the Bionic Pancreas. So in this study, patients are given the Bionic Pancreas and sent home, and we don't see them again for 11 days if all goes well. So they start on a Monday, and they finish the Friday of the following week. So not quite 2 weeks, but 11 days of Bionic Pancreas, 11 days of usual care, again monitored with a blinded continuous glucose monitor in random order. And this particular study is enrolling subjects who work or study or for some other reason are frequently at one of these campuses, our campus at MGH, UNC Chapel Hill, Stanford, and UMass Medical Center in Worcester. And we're doing actually 10 subjects per site. This has been changed. And they just do their normal routines. We ask that they live within 45 minutes of the study center and that they stay within an hour drive of the study center, so if they need any technical help with the device, we can reach them easily without inconveniencing them. We do a minimal amount of remote monitoring only to make sure that the device is functioning, or if the subject has blood glucose that's less than 50 for more than 15 minutes, we will call them and make sure they're all right. But otherwise, we don't do any monitoring. We don't know what their blood glucose is from moment to moment, and we make no restrictions on what they eat or what their activities are. And we've completed now 7 subjects, and we have in both at MGH, and we've completed subjects at UMass Medical Center, and we'll soon be moving on to Stanford and UNC Chapel Hill. And we're going to complete this study in the first quarter of 2015. So this will be the first unsupervised, unmonitored, except for severe event study in a completely home environment. We've added a couple features on the user interface. There's now this extra safety icon, and this can be used to give a one-time dose of glucagon if somebody is going to disconnect from the system because they're going to take a shower or go swimming, and their blood glucose is in the normal range, but maybe in the lower part of the normal range, and they don't want to take carbohydrates. They can give a one-time dose of glucagon to boost their glucose up before they exercise. They also have the capability to do a temporary target. So if somebody is going to be driving or going to be concentrating intently on something, doesn't want to pay any attention to the glucose, or if they let's say they're taking part in an activity like a surgeon operating, and they don't want to have to even, they want to take no chance of coming even close to the hypoglycemic range, they can raise their target from the default. They can't go below the default, but they can raise from the default by 15 milligrams per deciliter or 30 milligrams per deciliter for any time period that they want, or they can even permanently increase their glucose target. And so even though we have on average about 1.5% of the time less than 60 milligrams per deciliter, if someone would choose to sacrifice a slight increase in their mean blood glucose for a further reduction in that hypoglycemia, then they have the choice to do so. The boundaries for our sites look like this. For people who are participating in the MGH study, they need to live within this blue line, and they need to stay within the red line territory. And so you can see that this gives them a lot of freedom. For our Stanford site, for those of you familiar with that geography, here's Stanford. They need to live within these red lines and stay within the blue lines. And the Stanford site complained a little bit about not wine country not being included, and perhaps not enough beach territory. I found that funny because I guess we do have more beach than they do, but our water's too cold and we don't have any wine country, so I think they're all right. But anyway, this allows subjects to really live their lives and test the system in the most rigorous way possible. So our timeline, we did the Beacon Hill study in 2013. We did a camp study in 2013 and another camp study in 2014. We're working on the Multicenter hospital staff study now. And going forward, we're planning to do a few other studies in 2015 where we look at the impact of the set point and we look at the impact of alcohol on the effectiveness of glucagon. But then we hope to be moving to pivotal studies in 2015 where we'll be using a fully integrated device that has both insulin pumps and the glucagon pump and the CGM receiver and the Bionic Pancreas algorithm and user interface in a single device, and an infusion set that is a single infusion set with 2 entry sites for insulin and glucagon. Once we finalize that, we're going to go into the pivotal studies, and we hope to be submitting a pre-market approval, a pre-market application to the FDA by late 2016 or early 2017, which means that we could commercially launch a device as early as 2017. Now, one of the questions that one may ask is, what about glucagon? As many of you may know, glucagon is not very stable for long-term use, and what we're doing right now is we're using Lilly glucagon and simply reconstituting it from a lyophilized pellet every day. So that's not very practical and probably not approvable. So we've been working with a formulation produced by Xeris Pharmaceuticals, which is human glucagon, but formulated in a solvent that contains mostly dimethyl sulfoxide, which the FDA considers to be an inert ingredient. And this is stable for more than 2 years at room temperature and at least 6 months at 40 degrees centigrade. So this is a tremendously stable formulation. We've done some studies in pigs to show that there was no difference in pharmacokinetics or pharmacodynamics between freshly reconstituted Lilly glucagon or aged Xeris glucagon. So we can age it. This is aged 7 days, but in fact, by the time we got it, it was already 6 months old. So this is 6 months, and this is 6 months and 7 days. The point is that the Xeris glucagon is stable, and it, at least in these pig studies, behaved very similarly to the Lilly glucagon when made fresh. And I have recently completed a human clamp study to compare the pharmacokinetics and pharmacodynamics of these two glucagons. And in some initial data, they appeared very, very similar. This is the glucose infusion rate. And you can see after we give a dose of glucagon, the glucose infusion rate goes down and then back up. And one of the really unique features of glucagon is this happens very fast. The glucagon can reach its maximum effect within 15 to 20 minutes. And this is at least as fast as taking carbohydrates. So we hope to be able to qualify the Xeris glucagon and be able to use it in future studies. And we're gratified that many other pharmaceutical companies are now working on other stable glucagon analogs or formulations, including Lilly themselves. So the take-home points here are that fully automated glucose control of glycemia is feasible with a bionic pancreas. You can announce meals, and that modestly improves glycemic control. I didn't show you this data, but it improves glucose control by about 15 milligrams per deciliter. It's not necessary. The patients in the adult outpatient study announced about 60% of their meals, but didn't announce about 40%. A bionic pancreas integrates a continuous glucose monitor, a computer algorithm to determine dosing, automated drug delivery, and a user interface. Microdose glucagon is effective to prevent and treat hypoglycemia. And this whole system, a bihormonal bionic pancreas, reduces mean glucose and hypoglycemia at the same time and allows everybody to achieve an average glucose that would allow them to meet ADA goals for control. So until there's a cure for diabetes, we hope that this bionic pancreas will dramatically improve glycemic control for people with diabetes, reduce the worry for them and their loved ones, and allow them to avoid long-term complications, and not inconsequentially reduce the amount of effort they have to put in. All they would have to do with this system is to make sure the insulin and glucagon reservoirs are changed at intervals, and that the system has batteries, and that they calibrate the CGM twice a day, and announce meals if they wish to do so. And that's a lot less work than people with diabetes currently do. And so we hope that eventually the current method of doing things, injecting insulin, checking blood glucoses with meters, will seem very, very old-fashioned, as shown on this Greek crater cartoon that was done by my friend Heidi Merritt. And it shows that these technologies are old-fashioned, and we hope to replace them with the bionic pancreas. And if you have any questions about our work, we post our current clinical trials and our papers on bionicpancreas.org, and you can also contact us there for more information. And I want to thank my colleagues at Boston University and at MGH and companies that have helped us with technical and material support, as well as our funders, notably the NIH and the Helmsley Trust and the American Diabetes Association, and the JDRF. Thank you very much for your interest.
Well, thank you. This is very exciting work, and we do have some questions from our audience. So let's start with the first one, which is, what do you think about type 1 diabetic patients being resistant to glucagon?
Well, we haven't seen any evidence for that in studies up to 5 days in length. We don't see an escalation of glucagon dose over the course of 5 days, and we don't see any diminishment of the effect of a given size glucagon dose up to 5 days. I guess the proof will be as we do even longer studies to see if there's any evidence of that in longer studies, but we haven't seen any evidence for it yet.
Okay, the next question is, the current CGM technology is not super accurate. The accuracy can decrease significantly during low glucose levels. A system that is solely depending on CGM readings can fail when CGM readings are not accurate. How does your system deal with this problem?
It is true that CGMs are less accurate in the hypoglycemic range. One advantage of the Bionic Pancreas is that it tries to maintain the glucose in the normal range. So most of the time we have the glucose in the normal range where the CGMs are most accurate, and we start dosing glucagon, for instance. We start reducing insulin dosing or stopping insulin dosing, and we start dosing glucagon before we ever get to the hypoglycemic range. Our goal is never to get there. For instance, we can start dosing glucagon as high as 180 milligrams per deciliter if the blood glucose is falling very, very rapidly. So we try to avoid needing to have high accuracy in the hypoglycemic range. But it is certainly true that we are dependent on the accuracy of the continuous glucose monitor, and that's why we've taken such pains to compare all the available systems and choose the system that's the most accurate. We're currently using the Dexcom G4, but we're using a second-generation calibration algorithm called the AP for artificial pancreas algorithm, and that is even more accurate than the one that I showed you. I showed you about 11% average error. This system, we believe, is going to get us down to the single-digit errors, which is actually more accurate than most point-of-care finger stick meters. So really what it comes down to is concern about calibration in our view. And we are very vulnerable to someone giving a bad calibration. If they really calibrate far off, that can put them at risk. One potential answer to that, of course, is to use multiple CGMs in the future. People have talked about orthogonal redundancy, that is to have two CGMs that sense glucose by different methods, and if they disagree by too much, you would sound an alarm. But the other thing that I think is really important to remember is that people can recover their glycemic awareness. The real risk is people who have hypoglycemic unawareness. But we know that if we avoid hypoglycemia, that the hypoglycemia awareness returns. So our system is very, very good at reducing hypoglycemia. So our hope is that if you're on our system for a while, you will recover your ability to sense hypoglycemia. And if there was some rare catastrophic problem where the system didn't know you were low and wasn't preventing it, that you would have recovered your ability to sense that hypoglycemia. And so therefore would realize that something was amiss and recalibrate the sensor.
Okay, the next question is, do you anticipate the need for regular monitoring of blood glucagon levels in patients who will use the Bionic Pancreas?
Well, we don't. We have been doing that. I didn't show any of that, but when we did our inpatient studies, we had 3 inpatient studies, and in each of those studies, we checked insulin levels and glucagon levels very frequently, as frequently as every 10 minutes for glucagon, and then we spaced it out to every 20 minutes because we found out that was sufficient. And what we found is that glucagon levels are usually in the normal fasted range for glucagon levels, which is 50 to 150 picograms per ml when you use an old radioimmunoassay. And we're actually about to start to evaluate some new assays, including a Mercodia assay, to see if we can get more accurate results for that. But the point is that even with that assay, it was calibrated against the a normal fasted range, and we're in that range about 80% of the time. And the average glucagon levels are within that range. They're below 150 picograms per ml by that assay. So we think that because glucagon is an endogenous hormone that is present in everybody, whether or not they have diabetes, and it's still present in people with diabetes, although it no longer responds to the appropriate cues. It no longer rises in response to low blood glucose levels. In fact, I would argue that people with type 1 diabetes are glucagon deficient, and we are trying to replace that missing glucagon. Our hope is that this will be very safe over the long run. And we are going to be obviously testing that in longer studies. Our pivotal studies are planned for at least 6 months of exposure to Bionic Pancreas and to chronic microdose glucagon. So we will look very carefully at safety measures, and we'll know whether that's safe. And we also have a pretty good idea of what the glucagon levels are going to be for a given glucagon dosing. So we can look at the glucagon dosing that someone's going to get, and we can correlate that with our inpatient studies and know what their average glucagon levels are going to be. And so we're going to be looking at that very closely, but we think of this as essentially replacing a missing hormone. We may wind up having a little bit higher levels than would be physiologic, but that's also true for insulin. Whenever you give a drug subcutaneously, you wind up having slightly higher than the levels that would occur in somebody without diabetes, because there's a big first pass effect when insulin and glucagon come out of the pancreas, go into the portal vein and into the liver, and of course when we give it systemically, we don't have that. So I guess the short answer is that we're going to be closely looking at it, but based on the levels we've seen, we think it's going to be safe.
If exogenous glucagon is necessary to supplement deficient or dysfunctional alpha cells, does this quote-unquote dysfunction deteriorate under Bionic Pancreas? That is, does the glucagon requirement increase over time?
No. You essentially get a nearly complete deficiency of glucagon response to hypoglycemia very soon after diagnosis in type 1 diabetes. It happens faster in kids than adults. There's a very nice Yale study that shows within 1 year of diagnosis, there's essentially no response of glucagon to hypoglycemia anymore. So this is something that is just gone in people with type 1 diabetes, just like their insulin secretion in most of them is just gone. And so there's no way it can get worse. We are essentially replacing a function that is completely lost. In people who still have some C-peptide, a small amount of insulin production, they also have a small amount of glucagon responsiveness. And what we know in those people is the better glucose control you get, the more you can conserve that remaining beta cell function. So you can preserve C-peptide better if you maintain tighter control. So we would argue that we would probably maintain better glucose control. We know that we can do that with the Bionic Pancreas. We would also therefore preserve beta cell mass, and that preserved beta cell mass would also probably protect this glucagon function, because it's thought that it's a paracrine effect of insulin that regulates glucagon production and allows it to respond to hypoglycemia. So to the contrary, I would think that we would probably actually preserve whatever residual effect there is, if indeed there is any.
Okay, and our next question: does the Bionic Pancreas' dispensed glucagon mirror endogenous glucagon secretion in amount and timing in healthy individuals?
Well, it certainly mimics it in terms of timing. So there's a very nice paper by Khatib et al. In the Mayo, it was in diabetes care there at the Mayo Clinic. And what they did is they looked at people with diabetes and people without diabetes, and they fed them a meal and then had them exercise. And what you saw was that the people with diabetes, blood glucose went up higher and then took longer to come back down than the people without diabetes. But in the people without diabetes, when their blood glucose started to drop towards the normal range, there was an increase in their glucagon levels. So as they were coming through the normal range, towards the bottom of the normal range, there was an increase in glucagon. The same thing happened when they exercised. When they exercised, their glucagon levels went up, presumably a physiologic response to prevent hypoglycemia and to make more glucose available to their muscles from the liver. That's exactly the times when the Bionic Pancreas winds up dosing glucagon. Now, whether the amounts are the same, I can't say. I need to investigate this more to see if someone has really done, for instance, portal venous sampling to determine the exact glucagon output from the pancreas. I don't know what that is. My guess is that we're probably going to be giving more than that for a couple reasons. One, because we have to give the glucagon subcutaneously, so we don't have the advantage of getting that first pass effect to the liver. And two, because we're giving insulin subcutaneously, and we have this very long tail of insulin, so that if somebody exercises, we can't take back the insulin that's already been given, and we probably are going to have to give more glucagon to counter that than somebody without diabetes would have to give, because they're giving the insulin IV right to the liver, and so they can stop giving it and get a reduction in that insulin effect very, very fast. So we have a couple disadvantages when you compare our bionic pancreas to the endogenous alpha and beta cells. So my guess is that we're going to give a little bit more glucagon than endogenous, but I don't know exactly how much more. And that's something that we intend to do more investigations in.
Okay, our next question is, for those with residual production of insulin, are there plans to adapt the programming of the bionic pancreas to expand its utility?
Well, so in our most recent trials, we have not required people to have no endogenous production of glucagon. That was something that we did early on because we wanted to test our system against the most rigorous test. That is, it would have no help from endogenous insulin. But in our home studies, and in our studies with the 6 to 11-year-olds, we no longer require that. And we suspect that significant numbers of those people were, in fact, producing endogenous glucagon because some of them had very, very good blood glucose control, better than you might expect that would be achievable in somebody who had very brittle diabetes. So we think that we are testing it, and we actually plan to do glucose tolerance tests or mixed meal challenge tests to quantify the amount of C-peptide that those people are still producing, to know that for sure. So we believe that's actually an easier case. The bionic pancreas only gives as much insulin as it needs to bring the mean blood glucose down to the target range. If the endogenous insulin is doing some of the work, then the bionic pancreas just does less of the work. And we actually think that the system will work very, very well for people with type 2 diabetes who actually produce a lot of their own insulin. They just have a higher need. Once they become insulin dependent, I think bionic pancreas would probably be an appropriate thing for those people as well, although we have not tested that yet. We do have plans to do a study in people with insulin-dependent type 2 diabetes in the future. And because of the adaptive nature of the bionic pancreas, we believe it'll be able to adapt upwards to the higher insulin requirements of those patients.
Okay, our next question. It seems the decision in the algorithm is based on 18 hours and not 24 hours. Why?
It's not based on 18 hours. It's based on a moving window. And so, and then that moving window is about 24 hours in length. But when we first start the system, it knows nothing about the patient except their weight, literally nothing. And we've done that on purpose. We don't tell it what their previous insulin dosing was, and that's because their previous insulin regimen may not be a very good one. And so we don't want to get into a situation where we have garbage in, garbage out. We're telling the algorithm something that is not optimal. It also is because if you condition the algorithm on the pre-existing insulin regimen, you may over-constrain it. And we need it to be able to adapt freely in response to changes in the insulin requirements. For instance, when someone starts to go into adolescence, their insulin requirements skyrocket. We want the system to be able to adjust to that. So what we have is a moving 24-hour window. So it's keeping track of what's happening in the past 24 hours and adapting as it moves forward. But when it starts with 0 hours, and then it has 1 hour of data, and 2 hours of data, 3 hours of data, 4 hours of data. And by the time it hits 18 hours, it's essentially completed its adaptation, and then it just starts this moving window that goes forward that's 24 hours in length.
Okay, we have two more questions. The first is, will this technology be sold to an outside company for FDA submission?
So I'm not going to talk yet in detail about how that's going to happen, but I think that we think it's important for the people who've developed this to continue to be making the decisions about how this is going to be developed and reach commercialization.
And our last question, how affordable would the Bionic Pancreas be for an average patient?
Well, we think that there is a very good case that every insurance company and Medicare and Medicaid should cover a system like this, because the biggest cost of diabetes is actually the cost of treating the complications. As I mentioned earlier, the diabetes is the leading cause of blindness in the United States. Diabetes is the number one cause of non-traumatic amputations. It's the number one cause of kidney failure in the United States. All those things are tremendously expensive to the healthcare system. It also is a tremendous cost associated with hospitalizations due to severe hypoglycemia and to diabetic ketoacidosis. And we believe the system would be able to almost eliminate all those hospitalizations and reduce complications by 80, 90% or even more. And so for me, it's a no-brainer in terms of long-term cost reduction. And we're going to work very hard to make sure that we make that case to insurance companies and Medicare and Medicaid. But in terms of the cost of the system to an insurance company or to somebody who didn't have insurance, we believe it will be a little bit more expensive than current insulin pumps, because it will actually incorporate two pumps and the CGM and all the Bionic Pancreas algorithm and an infusion set that is a dual infusion set. But it doesn't have to be dramatically more expensive than current insulin pumps. We certainly don't know what it will be priced at, but I would guess not double what a current insulin pump costs. And it certainly provides much more than double the functionality. And we're just going to push hard to make it available to everyone with diabetes.
Okay, we actually did get one more question, and that is, dynamics of different meals, such as breakfast and dinner, are completely different from each other. Making a decision for dinner using information from breakfast period may not be a good assumption. Would you please talk on this?
Yeah, so the system actually doesn't do that. It uses, except in the first 24 hours where it only information it has about, say, dinner is the information it had from breakfast and lunch on that first day, and that's why it starts off conservative and starts to adapt. As we go forward, it only uses information about breakfast time adaptation for the next breakfast and information about lunchtime adaptation for the next lunch and so forth. So once you get past that first 24-hour period where you're starting at zero, it then is adapting on the basis of each of those meals individually. And that's also true when people do meal announcements. You notice on that screen I showed, it was you could choose breakfast, lunch, or dinner in choosing your meal announcement, and it then adapts, and you would then choose smaller than typical, typical, or larger than typical. It keeps track of all of those separately, and so it's going to adapt your next breakfast based on previous breakfast and your next lunch based on previous lunches.
Okay, well, this concludes our webinar today. I'd like to thank all of you for joining us and give a special thank you to Dr. Stephen Russell for an excellent and a really fascinating presentation.
I appreciate the opportunity to talk to you all.